Hello and welcome, and thank you. Thank you for joining us today, and thank you to NHS IQ for hosting this event, this series of events for us, and to PICA for supporting us. As Sandra said, this is the second of our series of 6. I think technology is amazing. We've got about 20 people on the line already. We're expecting another 5 or so. And we're all together at the same time in the same place, yet all over the country, which is amazing. As Sandra said, the videos are being made available, the sound is being made available on the NHS IQ website, and it will also be on the PEN website shortly soon as well. So what are we going to do today? Well, I'd like to I guess set a little bit of a backdrop for you. All of our webinees, so you're the webinees, have the opportunity, as Sandra said, to ask questions, and we really welcome questions. Feedback that we had from last week was that we did not allow enough time for questions. So you will see today we have 3 speakers, our intention is that we're giving each of the speakers 10 minutes to speak, but then you've got plenty of time to be able to ask them questions at the end. So we were originally planning 4 speakers, but we heard last week we packed too much into our time. And actually it'd be much better for you, our webinees, to be able to hear 3 great stories and then have the opportunity to really ask them some questions. And if you find you haven't asked all the questions you want, or you thought of a question later, in the bottom left hand of each screen, you will see the Twitter handles of the speakers when I show their details, but also for the whole series, which is Penna, #Penna2015 and #PatX. So we'd be delighted to continue the conversation after the webinar using those. And if you want to approach the speakers directly, you'll see their own Twitter handles on their slides. So today I'm going to be kicking off with a tiny little bit of information about the winning principles and an overarching framework. But then very quickly we'll be introducing Samina and Leslie and Rachel, 3 wonderful speakers who have some great stories to share. Why did we invite these particular people to speak? Well, because they were winners of, they were participants and winners of the Patient Experience Network National Awards in 2014. They weren't necessarily all winners of their categories, but they took part and they were shortlisted and were finalists and therefore winners in their own right. I should note at this point that the PEN Awards are open for entries, and you may just have received an email from us letting you know that we're extending the deadline to the 4th of December. So you still have time if you want to be one of our winners this year. So from the PEN Awards, we spent some time interviewing our participants, winners, finalists, people who took part this year and people who took part in previous years. And we were looking to understand really what are the principles, what are the winning principles, what are the things that our people who take part have in common. And I guess it will come as no surprise when I show you some of the 9 principles that we found. And they can be clustered into 3 groups. One is around the intention and outlook. So our winners and finalists and people who took part in the awards said, actually, the things that we found when we were putting together our best practice were our passion and determination was critical. As I said, perhaps not unsurprising. They were also saying that a critical element for success is being able to support and educate our colleagues to embrace and adapt work that's going on elsewhere. They also said, and we saw from the submissions, that actually a key element is being able to make it simple, make it accessible, communicate effectively. The second cluster was very much around the organisation support and infrastructure behind them. And as, again, perhaps no surprise, the culture is a culture where everyone is engaged in the patient experience and understands the crucial role this has to play. The management are equipped to support it, a very, very key element to success. And, of course, the leadership. Now, I've said these are the winning principles, and one of the elements that we did identify is many of these are present, but sometimes not all. So when you're looking at your own best practice, please don't be surprised if you find that some of these aren't present in your own organisation. But moving forward, these are the elements that we've seen are the key principles for most submissions. The third cluster is evidence and impact. And for evidence and impact, it's around financial impact, sometimes quite difficult to measure, but in many of our submissions we found that they had managed to find a way to measure their financial impact. But also the impact in terms of building professional relationships, looking to partner with people both within and outside of the organisation. And finally, the evidence of being able to spread and sustain the best practice. So those are the winning principles that we drew out from the people who've taken part in our awards. As I said, perhaps no big surprises there, but these are the 9 facets that seem to be a common thread across the winners and people who take part in the awards. Today, we're going to be seeing examples that are great examples around building professional relationships. So, moving forward. I will in a moment be handing you over to Samina, who will take you through her case study. But before I do that, I just wanted to remind you about questions. If you have questions, use the chat box or the question and answer. There is time set aside at the end, but if you'd like to raise your question during the presentation, please do. If you find that you would like to raise a question or continue the conversation afterwards, please use the hashtags you see there. Don't forget, this is session 2 out of 6, so please tell your colleagues about the next sessions. We'd love to welcome them on board. So at this point, I will be handing over to Samina, who is from the Black Country Partnerships NHS Foundation Trust. You can see their hashtag or their handle at the bottom left-hand side of the screen. And Samina will be telling you about their success with digital storytelling workshops. So Samina, I'd like to hand over to you.
Thank you, Ruth. I would like to talk to you about a project that was initiated at a psychiatric hospital where inpatients... Hello, so I would like to talk to you about a project that was initiated at a psychiatric hospital where inpatients were supported to record and share their own stories using digital technology about the things that are important to them in their lives. We belong to the Black Country Mental Health Foundation Trust, which caters for a diverse multicultural community. Hallam Street Psychiatric Hospital is a 54-bedded unit consisting of 3 houses. Each house or ward has 18 beds consisting of 9 male beds and 9 female beds. We give intensive 24-hour inpatient care to people who need more support than we can give them in the community. Nurses, psychologists, occupational therapists and psychiatrists are the staff team that help people on their journey towards recovery. We also have a home treatment stroke crisis team on site, whose patients were also involved in the project. So through a series of innovative workshops, creative practitioners work closely with patients to enable them to script and devise their own digital stories. A digital story is a short film that tells a personal story using computer-based tools, usually containing a mixture of images, text, recorded audio narration, video clips, and music. In the busy world of inpatient mental health and staffing pressures, listening to clients talk can be seen as a low priority. This project bore out of an earlier initiative, the Narrative Project, to determine whether the process of creating a narrative impacted upon therapeutic relationships between staff and clients, and whether narratives could improve clients' insights. The process also improves staff confidence in their skills and increased client satisfaction of their care. The Digital Storytelling Project was the second phase to this project as a means to creatively engage a marginalised client group. As a psychologist, I explore what sense people make of their journey, and the prospect of people learning to use new tools to support this process really excited me. I contacted Multistory, a charitable organisation in Sandwell that delivers creative projects. We felt that the process would add value to and benefit our service and extend the therapeutic value of narrative work in a creative way. In terms of the referral criteria, we found that clients should be of no risk to themselves or others. The group was open to 3 acute wards and the crisis home treatment team. There's a huge benefit an evidence base to this sort of work. It can improve communication skills. It can help increase participant confidence in themselves. It also offers a forum for discussion and dissemination of individual experiences. A lot of people have also talked about increasing literacy, visual and computer skills. It can create a level of objectivity for the participant, which can give the opportunity for personal circumstances to be seen in a more detached light. It can also act as a very powerful advocacy tool. And it's a wonderful opportunity for clients to see their own words grow into a complete broadcast quality movie. It can create meaning from experience by building connections with prior knowledge, but most of all, it's great fun. Digital storytelling provides opportunities for people to speak, to be heard, and to share their stories with others. In digital storytelling, the equipment and technology used is basic and accessible. As people's familiarity and skills in using technology differs from person to person, therefore the main emphasis of this process is on the narrative rather than the use of technology, but the approach can be adapted in accordance with the specific needs and skills of the participants. Its flexibility comes from the fact that in order to elaborate a digital story, participants can use a range of tools from the simplest forms, such as their voice and existing photographs, to more complicated ones using film or animation. The project team consisted of myself, Carl Greenwood, and Matt White, an external artist, both of Trust and Multistory. We ran a series of workshops with patients to enable them to script and devise their own unique story. The workshops complemented and aligned themselves well with the existing narrative project. There are a number of factors to take into account when working on a story: the complexity of the story and scripting it, the availability of visual materials such as photos and film, the personal needs and skills of the individual taking part, the literacy skills of the patient, confidence and anxiety issues with the patient, conflicting commitments for the patient as well, people being discharged from the hospital and not attending sessions. We managed to, despite some of these challenges, to deliver 8 full-day sessions in the hospital, working with patients on a rolling basis, setting up hourly or 2-hourly sessions after each session until the story was complete. At the end of each session, an evaluation meeting took place with each patient, and also the permissions to use the story were discussed in order for the hospital and Multistory to be able to show the story in public forums, such as online and for educational purposes. In collaboration with Multistory, I coordinated the showcase event, where these very poignant stories were shown to patients, carers, staff, management, and family were also invited to the event. I'd just like to share some comments that we had from some of the clients that took part. It's to tell the world, even if we have a mental health problem, we can still tell stories. We are still people. I still have my sense of humour. I'm strong and I want to preserve nature. For some of the clients, it was really important to be able to learn new skills. We'd be encouraged to create our own story, but it would allow us to do more than this. We'd learn to use a program and use digital equipment. For others, it was about destigmatizing mental illness. To help other people, if they read my story, it might help them. They can't give up. There is a light at the end of the tunnel. I feel there is life now. We felt that we gained huge achievements out of this project. You know, it provided patients with the opportunity to tell their stories in a therapeutic environment. It allowed people to self-reflect on their journey so far, help them think about coping strategies in quite a creative way. It also helps us as a hospital unit to have the opportunity to improve service user involvement and listen to their experiences and reflect on our own practice. Our project has been successful in engaging both clients and staff and has made a significant impact on the therapeutic milieu on the wards. We've had a similar project published in the Counselling Psychologist Review, and we've created poster presentations for the ward as a means of disseminating the results and findings. And these have been discussed in both community meetings, reflective practice forums, and in trust meetings. With regard to our future plans, we continue to support staff through reflective practice to think about the importance of the patient narrative and encourage staff members to listen to the patient journey. We have utilised the DVD of digital stories in mental health awareness training and support staff to develop their confidence to ask different questions creatively. The digital stories were also placed on our Trust website, and there's a link there that you can have a look at later. This generated a great deal of interest amongst our colleagues in other areas in the Trust who wanted to share ideas. The project itself has already had a profound impact on the Trust, its staff and patients. It's contributed to staff training, encouraged practitioners to continue to focus on the patient narrative. Some clients who participated found the process so therapeutic that it changed the way they engaged with the system. Developing such a strong partnership with an external agency was a very new experience for us. However, it proved so rewarding and has highlighted that forging partnerships with external services, despite the challenges, can bring many rewards and learning opportunities. And we hope to foster continued working partnerships. Thank you. It's my list of references and further reading. I'll pass it back to Ruth.
Brilliant. That's Samina, thank you very, very much. That was a really interesting story about your storytelling. I don't know if you had any questions directly, but if you do have questions for Samina, please do start to capture those. Today we have three very different case studies. So we've heard from Samina and the Black Country Partnership and their work with digital storytelling. Next, we'd like to introduce you to Leslie Goodburn from the Midlands and Lancashire CSU, who will talk to us about using insight across the healthcare system to improve care. So Leslie, at this point I'd like to hand over to you, but before I do, if you'd like to tweet about Leslie or to Leslie, you'll see her details in the bottom left-hand side of the screen. So over to you, Leslie.
Afternoon, everyone. I'm going to share with you a story around some work that goes back to before CCGs were created. So I'm Leslie Goodburn. I work at Midlands and Lancashire CSU, working in site and involvement, and I'm the service partner for that service. So it's anything around patient experience, public and patient involvement, consultation, anything to do with patients. We cover 24 CCGs across Midlands and Lancashire. We do lots of different things, but the most important bit of the work that we do is the communications and engagement function, which is the bit that I work in. We also do business intelligence and other things. So I'm going to take you through the journey so far, which stretches back about 6 years. I joined the NHS about 6 years ago. I joined a PCT called NHS North Staffordshire. At the time in Staffordshire, there was a little bit of an issue with a hospital called Mid Staffordshire, where a number of issues about poor care started to initially come out. This was at the time before there was actually a public inquiry into the Mid Staffs, and NHS North Staffordshire wanted to make sure that they put some contingencies in place to start to capture patient experience in a very kind of systematic way to develop themes and trends. So at that point in time when I joined, and I was from a kind of retail company, new to the NHS, slightly different approaches. At the time, the strategy for NHS North Staffordshire was that patients were kind of there, they were outside the door was slightly ajar, everyone knew that they needed to do the work with patients. What we were able to do over a period of time was make patients, carers and the public much more involved, started to get a foot in the door for patients. Eventually we kind of got that door wide open, and in some respects over that period of time we've managed to get rid of the door and start to work in equal partnership with patients. At the time when things started to change, very much about patients, carers and the public being at the centre of everything, and as CCGs started to form with all the different parts of the system, patients, carers and the public were very much at the forefront of the thinking. So rolling the clock back 6 years, I looked after public and patient involvement, complaints, patient advice and liaison and individual funding requests. So we started to think about how we could take the various different pieces of intelligence that we got from those sources and put them into one system, one database that we called Customer Insight. So we started out with complaints and individual funding requests, placing the intelligence that we got from those into a system, and started then to include patient advice and liaison. PALs would go out to the community, to various different groups, talks, voluntary sector organisations, and from there we started to build up a membership scheme where people would give us the details, join up, and would get information about health each month. But what we were also able to do was, as we started to build this database of information and we started to get themes and trends through, we could start to then double check that back with the membership to check whether or not they'd got any additional intelligence. And what that started to do going forward was very much about driving the public and patient involvement that we did. So rather than it just always being about commissioners going out and talking to the public about what they wanted to change, we started to use the patient voice to actually shape the engagement. So for example, at the time we did some big pieces of work around podiatry, continence and orthotics, which were shaped completely by the themes and trends that were coming out of the patient database. So we were able to then put patient advice and liaison into the system, complaints, if we did any surveys or public consultations, focus groups or deliberative events. The feedback from that went into the system, anything from patient participation groups and the mystery shopper scheme. So we were capturing lots of patient experience from different angles, all into the one database. What we found was we'd got loads of information, but we couldn't really understand what it was telling us. So we developed some domains of patient experience, 5 domains, which would cover off most of the areas of care: access and waiting, clean, comfortable place to be, safe, high quality care, building closer relationships, and better info, more choice. So very much the 5 domains that would be the key capture, and underneath those, subdomains that we could then categorise. So for example, with complaints letters, quite often people will write a complaints letter, they might only want one issue addressed, but actually there's lots of intelligence in there. So for example, we could capture information under the various different domains of patient experience and allocate those to various different providers. So if the patient was talking about seeing a GP, maybe not getting the diagnosis, ending up in A&E, ending up on a ward, then being discharged, then maybe using community services, actually within that complaints letter you could capture the information under the domains and allocate those to the various different providers. So we've got lots of intelligence, lots of different ways of reporting. We could report the public and patient involvement work that we did, which was the proactive work going out and talking to patients. We could report the reactive PALs and complaints, or we could put it all together and we could report together. So you could look at the domains of patient experience, you could look at the sub-subjects, you could start to see the organisations. We categorised the care into primary care, which were GPs, opticians, pharmacists and dentists. Secondary care was any of the acute providers, whether it was mental health, acute, community services, and support captured anything around public health, screening, commissioning decisions. You could segment the information by division, directorate, by service, whether it was clinical or admin, and you could even go down to kind of person level if you've got some intelligence about a particular consultant or a particular GP. What we also did at that point in time was decide that actually to support this insight work, we would set up a model of involvement based on the membership scheme, looking at how we could set up a strategic structure that would allow the patients to get access to the patient voice and be able to work in partnership with the CCGs. So by this point in time, the Health and Social Care Act had come into place. We'd moved from being in part of a PCT to starting to set up a commissioning support unit. We'd gone from working with 1 CCG to 6 across Staffordshire. So we took the approach that actually the membership scheme would be the kind of keystone to the work. We could have patient participation groups helping us to recruit to the membership scheme. We could segment out part of the membership scheme to provide a virtual group for the patient participation group. We also then took the opportunity to allow patients to be involved in commissioning decisions rather than just from a GP level by using locality groups to get them to look at local JSNAs, Joint Strategic Needs Assessment, and start to broaden people's thinking around what commissioning should look like locally based on the local area. We also set up a patient congress. That was a strategic group that had a job spec, it had a payment, It was made up of representatives from the locality groups, from membership, and also from various different third sector groups and voluntary sector groups. So very much about cross-fertilisation and being able to work in partnership with the clinical commissioning group. The patient congress was chaired by the PPI lay member who reported directly into the CCG board. And from board to kind of GP level, patients were involved in the decision-making process. What we were able to do then was run the two models together. So actually all the arrows on the model of involvement would feed into the insight database, and the outputs of the database would feed into the patient congress, where we would be giving the patient voice to the patients to have a conversation with the clinical commissioners around what exactly patients were saying locally and whether or not clinical commissioners were listening to what patients were saying or just kind of working on what their strategic needs were. So the two models working together. We used a system called Datix that some of you may be familiar with, but we were able to configure it in a particular way so that each of the CCGs could report their own data separately, could also report the data across a health economy. So the 6 CCGs in Staffordshire would all have their own data, but would also then, at a strategic level, be able to share that data so you could start to spot themes and trends from providers. All the data was available in real time for them. So if you were the Commissioner for Stroke Services, you could see the information specifically about the services that you commissioned. If you were in a GP surgery locally, you could see the information and feedback that was coming through that related to your surgery. So all that being interactive, real time, and configured based on people's portfolios. What we've been able to do over a period of time is allow different parts of the health economy to use the information. So just remembering that this is all from a commissioning point of view, this isn't from a provider point of view. The CSU used the information in there in terms of contract monitoring, quality, public and patient involvement. Your clinical commissioning groups are using that for board reporting, clinical directors, commissioning managers, and also in some cases sharing the information with public health and the local authority. And GP practices. The NHS England local area team have been using the information based on dentists, pharmacists and GPs. And then you've got your providers who are around the outside of the system who are still collecting their own information in their own way, but what this system is doing is allowing commissioners to calibrate their information against what providers are sharing with them. So that took us to a point in time as a CSU where we'd gone from 6 CCGs to 49. So all 9 of the CCGs were taking various different approaches to it. Then Stoke-on-Trent CCG said, that's great, we're looking at patient experience, but now let's think about all the clinical effectiveness data that we probably get from GPs around discharges with cannulas still in people's hands, information around diagnosis, all those kind of things. So what we were able to do, working in partnership, particularly with Stoke and North Staffordshire, was roll out the system to 54 GP practices in Stoke and 33 in North Staffordshire, so that the GP practices could also enter their own patient experience feedback. They could enter clinical effectiveness, any feedback they were getting from patients around issues with the hospital or issues that the GPs were experiencing, and their own safety issues at primary care. So what it then turned into was a kind of quality system rather than just focusing on patient experience, but because all of the data was going in together, being captured against the domains, it gave the full picture. So where are we now? We've completed a rollout across 9 CCGs and 350 GP practices in Staffordshire, Shropshire, Telford and Herefordshire. We've also done some work with 3 CCGs in Lancashire and 88 GP practices. We've got the NHS England local area team using the system, as well as some out-of-hours providers in Lancashire. And we've also been able to use the system with a couple of condition support groups, particularly in Staffordshire. One of the mental health support groups is able to put their own feedback in. They can see their own feedback, and if they choose to share that with the CCG, they can do, and also with Age UK. We've had some conversations with the Health and Wellbeing Board in Staffordshire. We've got a rollout planned for another 4 CCGs in Lancashire and another 250 GP practices. We started to work with some of the CCGs in Central Midlands. Birmingham South Central are starting to use it. And we've also more recently just done some work with Salford CCG and Salford Health Watch, which will see Health Watch starting to bring their data in. We've got rollouts planned to other condition support groups, lots of conversations about being able to use the system in care homes, and lots of discussions around potentially providers coming into the system and using the same system, or at least using Datex as a standalone system, but using the same kind of configuration in terms of standardized data sets. So what we've been able to do over that period of time is really bring a new focus to pulling together data, but keeping the kind of whole ethos of the NHS in mind. We've been able to bring together 2 different types of information. By using the involvement model and the insight model together, we're able to pass the patient voice from patients to patients to challenge the CCGs around the work that they're doing. And those 2 things coming together creates a very different kind of partnership. Over the period of time that we've been working through this, we've trained loads of people in terms of the events, the incidents at primary care. 98% of those are followed up with follow-up action. All the events and feedback are reviewed within 30 days. Data is shared across health economies. So in Lancashire, they've got their own kind of data sharing set. In Staffordshire, they have, and across Telford and Shropshire, they have too. Lots of hours spent reviewing the data and setting actions across the CCGs, and loads of people trained. Lots of things have changed as a result of this service over that period of time, from small changes about oiling a kind of GP surgery door to full clinical reviews of services, including community. Lots of things have come through the kind of clinical feedback around changes to referral systems, use of radiographers, just loads and loads of actions. And the system allows the actions to be tracked and audited through and allocated to people. We've won a few awards along the way over the years in various different categories. It's been a little bit of an uphill struggle because the changes to the way in which commissioners were set up and the move from PCTs to CCGs made it quite a difficult journey sometimes, and it did feel at times like we were kind of hanging on the edge, and on occasion it did feel as well like we were hanging there and somebody had kind of stamped on your fingers. But over the period of time, we've kind of found that we've scaled the mountain a little bit. But each time we've thought we've got to the top, somebody's thought of another way of using the system to bring information together. So each time it feels like we're getting to the top of something, it snows a little bit more, and there are more challenges there to take on. And that's me. So back over to Ruth.
Thank you, Leslie. And but isn't that the joy of what we do? Is there's always a mountain to scale. I'm not a mountaineer, but isn't that the fun of what we do? So brilliant presentation. Thank you very much, Leslie. And we're getting some questions coming through, and we definitely will have some time at the end of this session to tackle the questions. But one of the things I just wanted to reflect that Leslie said that I know is and hold dear actually is Leslie shared her journey with us over the years, and I was absolutely delighted that she was a winner this year, because these things do not happen over time, do not happen straight away. It doesn't happen overnight. So that was Leslie's example of what they've been doing. So very, very different, as you saw from Samina's example. And we're going to then finish off with a third example, which will be also another different perspective from Rachel. So Rachel White is from NHS England. And again, if you'd like to communicate directly with Rachel outside of this webinar, you'll see her Twitter handle and NHS England's Twitter handle down there in that left-hand corner on the screen. And Rachel will talk to us about what's the story with storytelling within the NHS. As soon as Rachel's finished, we will be opening up to questions. But Rachel, I'm sorry, over to you.
Okay, thank you very much, Ruth, and thank you everybody for joining us. I'm absolutely delighted to be given this opportunity to share the findings from this collaborative project. Storytelling is as natural as breathing. It's absolutely embedded in our DNA and woven into the very fabric of our being. We've been doing it since the beginning of time, and it's as natural as breathing. One of the sayings that I came across recently was this, Sawubona, which means I see you. It's a Zulu translation. They use this as part of their village life, and it really depicts a deep understanding of a person and who they are in the world. And I would suggest that sort of storytelling offers this opportunity. So we'll be talking a little bit more about that. We ended up with a legacy from the patient revolution when the changes in the NHS happened. Patient revolution had started some work around introducing stories at board level, and there was clearly ongoing national drivers and imperatives that were driving this work, but we wanted to be clear about where we needed to focus our energies and what was happening since the NHS changes. So we thought it would be a good idea to evaluate. And this was the approach that we took. We were really clear that we wanted this to be a collaborative approach. We were interested in looking at the process and the associated outcomes, not the stories themselves particularly. We adopted a distributed leadership model, and co-design was very clear with it. We wanted to ground the work in research-based methodology, and we used primary and secondary data sources. So we had a survey, but then people had to submit evidence against that survey to demonstrate their storytelling in action. And we were really clear that we wanted to do activities like we're doing today to share the learning and to influence thinking as we moved forward. Research approach was realist evaluation, and realist evaluation tries to get under the skin of what's going on and to understand the circumstances in which the programme is working. This was the research cycle that we adopted, so there was an iterative process of learning that went on throughout, and that influenced the work as we went throughout the project. All research starts with a working hypothesis, and this was the conjectured framework that was our starting point. So what mechanisms were in place, what context were they operating, and what was the associated outcome that we'd like to see as a result of that arrangement. And these were the responses that we got. You will note the sort of drop-off from the evidence returns against the surveys. And we actually got a commissioning support unit that returned a survey. However, this we hadn't made sure this was part of the initial criteria, and additionally, there was no evidence to suggest this was a commissioned piece of work, so we couldn't attach it to a particular CCG either, which was a shame because they were showing some incredibly great work. These were the initial high-level findings, and the final report, which I will tell you more about in a moment, gives the greater detail because all the findings were segmented into the organisations that I showed you in the previous slide. So where we had structured storytelling happening in a listening forum, we were seeing reportable actions and outcomes. Educational storytelling happening in a learning forum, we were seeing sort of individual learning and practice development happening. Where storytelling was happening at a board level and reflective time had been allowed, we were seeing evidence of board development. Where a story was told by the storyteller themselves in a forum using the structured processes and systems, we were seeing a real connection with hearts heads and hands. Second strand of the work was we mapped the findings against the review findings that happened in 2012. And this is what we sort of saw. There was lots of other findings, but these were the key things. That storytelling had been impacted by the architectural changes to the NHS. CCGs were steaming ahead. However, again, there was polarisation with this. Some CCGs weren't looking at storytelling at all, whereas some CCGs were really clear that they saw this as a valuable source of evidence and were using this in really great ways. Staff and carer stories were an important emerging consideration for storytelling organisations, and the patient leaders and volunteers were playing a critical supporting role. And as we've heard before, innovative approaches to storytelling were being explored and used. This is what we learned as an organisation. Clearly it will be of no surprise to any of you, but we probably needed to go through this process to learn ourselves because we were new in the system. NHS England was only sort of, first or second year in its conception, so we needed to learn ourselves. And we also sort of learned something that really challenged my thinking. I started from a position of, storytelling needed to be quite structured, needed to be quite formal to get the best from it. But I was really challenged by the findings of this project. And a whole heap of stuff is considered to be stories. Basically, it's wherever narrative is captured in some way that was considered to be a story. And the final result of any RE project is the final specification, because the original hypothesis is tested against the data returns and, refined, and this was what the specification looked like at the end. I also was able to use the data to highlight the areas where we were fairly good at in the region, where we were doing some work on this area, which is the brown sort of bits, and the bits where there wasn't much evidence that we were doing this very well at all, or there was very limited evidence around, which are the red bits. So this is now being offered as a sort of self-evaluation tool. It shouldn't be viewed in a linear fashion. Could be, any configurations that could make this work. And I would suggest that, storytelling organisations could use this as a sort of self-evaluation tool or an assurance framework. There was also sort of further impact as a result of this work. We did a whole heap of sort of road shows. We had a week of action that resulted in individual pledges. We did some publications. Further work has been the development of a 60s live resource hub where we've drawn together sort of storytelling resources in one place, because this is what people were saying they needed and wanted to be able to move storytelling forward. We also clearly needed to think about, what systems, what we've got in the system already that we could tap into and embed storytelling more widely. So Open and Honest is a programme of work that's going on at the moment, 2 clicks away from a Trust's front page of their website. They report on what they've done as a result of storytelling, but also they report their trust improvement story too. So we did some work to make sure that the metrics and the data set for Open and Honest included storytelling. And Open and Honest is now being made available on My NHS, which is, as you know, is the public-facing online site where data is being shared publicly to enable those quality conversations to happen at a local level. And we've got some further work going on within the carer programme of work for NHS England. There's a pilot site in Shrewsbury who's agreed to examine some work along health and social care economy around sort of using storytelling as an evidence source for from carers, and how we might use that to examine service developments or commissioning developments. So this is our sort of vision of success. We need to have, you know, this clear vision and strategy. We need that, you know, system thinking to be applied to storytelling so it doesn't stand in isolation. And this is some further thinking that I've done since. I'm not suggesting that any one way of telling story is any better than any else. But what I am suggesting is that context is pivotal to success. Michael West, who did some work around leading with care, suggests that we need to close that gap between strategy and practice. We can have all the strategies, processes, mechanisms in the world in place. It's the people that bring these alive, and they come to life because we're human. And I would suggest that a house of care needs to be wrapped around storytelling, so that it's incentivised and driven, and that all the components are in place to support storytelling really well. These are the acknowledgements from the study. Great thanks go to all these people that were absolutely pivotal in making this study happen. And take-home messages from this story, which I've articulated as we've gone along. But I would argue that a refreshed view of storytelling is required. It shouldn't be confined to service improvement, can and should be used for a multitude of purposes, and that societal changes and technology are driving this, and we should allow it to drive it more. And this is my final message.
Sorry, I'm reading the final message. Thank you. Thank you, Rachel. That was a very clear story that you took us through around the power of storytelling. Love hearts, heads and hands. I've not heard that before. Perhaps I should get out a bit more. Okay, so three really, really brilliant speakers. Thank you very much, ladies. And I can see quite a few questions. So we've got 8 minutes for questions, and please don't forget you can keep the conversation going afterwards on Twitter if you have a Twitter account, or indeed by email, good old email, go back to the old days. So Sandra, I know we've got a question from Corinne for Samina, I think it was.
Yeah, I've just unmuted Corinne. Are you there, Corinne?
Yes, I am here.
Hello, do you want to ask I think you put a couple of questions forward. Do you want to ask your questions for the speakers?
Can you hear me?
Yes, we can.
So the question for Samina was if she could take an example of one particular story and explain how long that process took for that individual, and then preparing it to present to others. Because I didn't get, that sounds fantastic, and I'd like to get a feel of that.
Hi, Corinne. Thanks for the question. It varies from one patient to another. It does. I mean, it's a huge investment of time. I think with some of the patients, I think it really depended on their personal needs and the skills that individual had when they were taking part. Confidence and anxiety issues were. It's really difficult to put a time to it. I mean, if I give you one example, there was a patient that I was working quite closely with who wanted to tell her story about her pet dog, and this dog was the only person in her life, in her network. Unfortunately, she was discharged halfway through her admission, and she really wanted to complete the story, so we ended up following her home actually, and we actually supported her in her home environment to get that story broadcasted and completed, and she came back to the showcase to share her story. I think including the workshop, the story circle, I don't know, 10 to 12 hours worth of work as a rough average.
Brilliant. Thank you. Corinne, did that answer your question? We missed a little bit of you, Samina, but I think we got the main impression.
Oh,
Samina,
sorry.
how many stories did you do?
I think it was about six
Okay.
stories. They're all on the website if you want to see them.
And we're realising why we mute the speakers. But does anyone else? I think Andrew, you had a question for Samina as well. Did you?
I was just wondering how scalable your solution was. It seems quite labour intensive to actually do. I was just wondering if there's any ways you thought of scaling it, expanding the reach, and advice you'd have for other people trying to do it elsewhere.
Thank you, Andrew, for that question. It was very labour intensive. And we were very fortunate to work with an external agency that
Mina, we can't
now
hear
at the
you,
moment.
I'm afraid.
Oh, sorry, can you hear me now?
Yes, we can.
Okay, sorry. So what we're hoping to, we've got a lot of skills in-house. We don't have any lottery funding now, and we are hoping to kind of roll this project out. So we've got people in-house. We've got people that are technicians that work in IT that can support me with some of the workshop ideas. We've got a number of occupational therapists and psychologists and volunteers that really want to get on board. So I'm hoping that we can probably do this without sort of a huge amount of funding. So yeah, it is very labour intensive, Andrew.
Brilliant, thank you. I'm conscious that they're all for you at the moment, Samina, and I know that there were some questions for Leslie, but I think Leslie's been answering those through the Q&A. Corinne, I think you have a second question for someone.
Yes, it was a question for Leslie, which I think she has answered to some extent. I was asking whether patient groups for particular conditions, for example, premature and sick babies or Parkinson's, whether there is any funding or support, facilitation support for those patient groups.
Through the project, there was no specific funding for those two particular areas, but through the patient congress work, any of the groups who applied to be on the patient congress and went through the interview and assessment centre and were successful, they got a small honorarium which would pay for their time to attend all the meetings and all the expenses. And the patient congress recruitment process was very much around condition support groups, third sector groups, voluntary sector groups, community groups coming together, and through that kind of recruitment process, then deciding which of the groups should be represented there. And it was often about reach out into the community. So, for example, on the North Staffordshire Congress, they got representation from homeless charities, housing associations, domestic violence, on the basis that those were some of the groups that actually we don't hear the voice of very often.
Brilliant, thank you, Leslie. Are there any other questions?
There's no questions in the chat box, but if anybody's got anything they want to ask, just click on the hand icon and we can unmute you.
And just as you think about that, I was exchanging with Richard. I hope you don't mind me mentioning Richard, but I know you put out there the customer word, and sometimes the challenges of calling people customers. Leslie, did you have any feedback or pushback on the word customer when you used it?
Originally, yes, because it was quite alien, perhaps 6 years ago, probably a little bit less alien now. But the whole kind of, I think the approach that I took was slightly more customer-centric, having come from a retail company and done lots of customer service work. And probably over the last 6 years, that has kind of toned down a bit, and I've become indoctrinated in the NHS world of patients.
Mm.
Not deliberately, that's just the way it happens, I think.
Okay. So it's 1 o'clock. I'm going to suggest if there are no more questions, we will just say a final thank you to everyone. I would really like to thank our speakers who have done an amazing job today. And a couple of the speakers mentioned resources on their slides. Just to let you know, those slides will be made available after this session, as will the recordings. But if you do have any specific questions, just get in touch with us. You can get in touch with them directly, us through the hashtags, or indeed through the email. A final thank you, apart from the speakers, to Sandra at NHSIQ and the team there for hosting us, for Picker for supporting us to make this happen, and for our audience today. If you've enjoyed it, please spread the word, and if you have any feedback, we'd love to hear from you.